Hi, this is Dr. David Schneider with Pure Orthopedics. I'd like to take a few minutes and explain robotic-assisted total shoulder replacement. If you go to any old hospital or look at some of the most important hospitals in the history of medicine, they all have one thing in common. They've got a big dome on top of their hospital. On the right, you see this picture of Massachusetts General Hospital in Boston. On the left, it's the Hospital University of Pennsylvania. And both these hospitals had domes at the top with ceiling light because surgery could only be done with the power of the sun. Yes, there were gas-lit lamps later in the 1800s, but it was light that provided the ability to see for the early surgeons. Here you see Johns Hopkins with William Halsted, the father of American surgery, operating, of course, with no lights, no masks, and with people crowded around these famous surgical amphitheaters. Even Harvey Cushing, who's the father of neurosurgery, you see transformation in his career where he had, the simple kind of mask finally doing brain surgery. But he needed to see more deeply into the brain, so later in his career, he had a headlight mounted on top of his head, an incandescent light bulb with heat and, of course, not sterile. But that was a solution in its time in 1925. But the cytolytic lamp changed things. One huge light bulb with a reflective mirror to try and provide light so surgeons could see. And on the right is Dr. William DeBakey, one of the most important early heart surgeons in Houston. Then some of the early pioneers at the Barrow Institute on the left, really important neurosurgeons had then more functional halogen lamps mounted between their eyes so they could see deeply into the brain, which then gave way to operating microscopes that allowed a surgeon to look with very great magnification deeply into the wound, as you see these two female surgeons on the right. Then it became the thing to do to be able to look at laparoscopic surgery. So here's someone doing abdominal surgery with a handheld camera, and then the cabling goes to the wall and you can see inside body cavities. And in orthopedics, we use arthroscopy and fluid to see in a joint. This is joint surgery with a scope. And here's a surgeon doing knee surgery, looking at the camera, at the big monitor, using the camera to look inside a joint. So it's really always been about the ability to see. So the first challenge was simple illumination, whether it was the sunlight or gas lamps, and then the next hurdle was illumination and magnification, like with OR scopes, microscopes. A huge breakthrough was then visualization of body cavities and joints that finally allowed minimally invasive surgery, but there was still no technology that harnessed advanced imaging studies like CT scans and MRI scans while you operated. So we have plain x-rays. Here's an arthritic shoulder, and we can then look at a CT scan and look at this arthritic shoulder and go back and forth and look at the cartilage loss and the bone spurs and loose bodies floating around. But no one had figured out a way to look at these advanced imaging studies while you operated in a three-dimensional sense until recently. So now we have 3D reconstructions of arthritic shoulders that we can use and think about, but in an even more advanced way, we have surgical planning now. So here's a patient of mine where we can get this CT scan of the left shoulder. This is a reconstruction of the shoulder based on the CT scans. And I can then go and do surgical planning. This is a patient who's going to get a left reverse total shoulder. I can make the bone see-through. I can look at the bone itself, the humerus. The red plane here is a so-called anatomical plane. The green plane is where I've decided to make my bony cut during surgery. And again, I can go and make the bone see-through and then put the implant in, which I've already done the sizing on this. And we can make sure that it fits perfectly and that it doesn't damage the surrounding bone. And we're using much smaller stems now, of course. We used to use stems that went halfway down the arm toward the elbow, but now we use much smaller stems. And we can see exactly where it all fits, and we know the biomechanical parameters that make it function well. Then we can look at the shoulder socket. And again, this is a reverse shoulder, so we're putting the ball on the socket side. And here's this base plate. I could then mount the ball on there, and then I can look at all three panels and make sure that it's aligned well, that it covers everything, and that this patient will have great function. Then, amazingly, we can dynamize it, and we can then ask the computer to simulate the patient's motion, where we can think about, will they be able to lift their arm and rotate and get a really good idea and make sure that they're going to really enjoy their new shoulder. So what did shoulder x-rays look like in the 1990s? When I started my orthopedic residency, sadly, these are all x-rays from the 1990s, and they're terrible. Surgeons today would never tolerate placement of implants like this. Either they're too proud, it's too high, or it's too low, and it doesn't function very well. And, experience from the 1990s and even early 2000s, you would hear patients say, well, I got a total shoulder replacement. It didn't work very well. And we can look back and say, well, no wonder it didn't work very well. We weren't placing the implants correctly. And we look at this and think, that's awful. And this is not that long ago that awful x-rays like this were commonplace. But one of the big things that happened was true modularity. That is to say, the implant came in multiple pieces, and each one of these pieces could be placed in a very precise fashion so that the stem was the exact right length, the stem is the exact right diameter, that the ball is perfect. So it's this level of customization that has changed everything, that gives us great x-rays. So the real question is, we've got all these great implants, and we know what we want the x-ray to look like because that correlates with great outcomes. But how do we perfectly place the implants? Well, one option would be to come up with that same CT scan and have a company build this white guide to couple in deeply into the shoulder and drive, so you can drive these pins in and then do the operation. And that was a breakthrough. It was kind of a neat thing to do a decade ago, but you had to wait for the company to make this implant for you to guide surgery. But what if we had a virtual guide for every shoulder, that we didn't have to wait for anyone to make something for us? And that's where we get to robotic-assisted surgery. So I always tell patients the Rosa computer robot functions as an assistant in the operating room by providing navigation inside the body, like using GPS to drive a vehicle. So here's a couple neurosurgeons in Europe. These pioneering surgeons also use the Rosa robot. That's actually where it originated, was in neurosurgery, to help neurosurgeons guide an implant deeply into an extremely small localized area deep in the brain. So you can map out the exact area where you want, and that robot behind this surgeon, coming up here in a second, right there behind him, helps guide that aiming arm exactly precisely to the millimeter where you want it. Well, Zimmer Biomet acquired that company and started doing hip and knee replacements over the last decade. But recently, this small team and several other surgeons who are not pictured here came together to develop the Rosa application for total shoulders. And we're pictured here in the hallway at the Mayo Clinic, and this was April 24th of 2024. We had full FDA approval. We assembled together as the team at one of the main Mayo hospitals in Rochester, Minnesota, for this gentleman, Dr. Sperling, to do the world's first robotic-assisted reverse total shoulder. On the left is Dr. DeQuinn, also a Mayo-trained guy who's now in New York, and I'm there on the right. And it was a really exciting day for something really pioneering. And so we rehearsed things the day before. Here's Dr. Sperling. I love this picture because it captures a surgeon deep in thought, thinking through everything that he wants to happen the next day for him to make world history. And this is us immediately after the operation. And here are the two doctors and the Zimmer Biomet executive, Christoph Gossen, there with us as history was being made. Well, my crew and I then, 2 days later, got to do the world's first robotic primary total shoulder in Colorado. And here we're practicing in a similar way with all my crew. And on April 26, 2024, we did the world's first robotic-assisted standard total shoulder. And people wonder what the robot looks like. Put the volume up so you can hear the chimings, what happens before the surgery when this mechanical arm can come into position where we'll use it in the middle of the surgery to know that we're exactly in the right spot. Here's the picture we took after that really momentous day. What is the robot exactly? So on the left is the robotic unit. It has that big mechanical arm you just saw. And then on the right is the optical unit. It's got an optical camera there at the top. And they're on opposite sides of the patient. So the robotic arm, here on the upper right part of this, is attached to this base unit. And the wheels lock in place and it's sitting in a solid place. There's the rear panel. And like I said, this optical camera, this optical unit is on the opposite side, and it is giving an idea where in space everything is. So again, this is the robotic arm, and it can move around, and it's got ability to bend at one joint and swivel at the next and careen around so it can go exactly where we want it to go. But the key for any type of robotics are these little fiducial arrays that have these little faces. So if you look at the two little faces I'm touching with my left hand, and then the one little face I'm touching with my right thumb, that cluster of three are all parallel perfectly with each other. Now, there's three clusters, but each one of those clusters has three little faces. And again, I'm touching the three that would match together. There, and there. And once the computer knows where those three faces are in that little triangular area, it knows exactly where that little joystick is attached. So here you can see those three, you can see three faces now. And I turn it here, now you can see the other three faces. And this is what gives the three-dimensional, extremely precise three-dimensional localization. And what that does, it allows us to develop this preoperative plan on the left, where we can now tell patients, this is what your x-ray is going to look like. You're super arthritic, you can hardly use your shoulder. But this is what it's going to look like. And then to be able to have the x-ray and it looks exactly like the plan. And we're able to carry that out because of the precision of preoperative surgical templating and the robot. So here's the shoulder. Sorry if you're squeamish, but through this small incision, we're able to map it out. That little tracker is then mounted, clamped onto the shoulder for a couple minutes, and then we're able to guide it in. Here I'm reaming and I'm using that robotic arm. So as the surgeon, of course, I'm in total control and I'm using it, but the computer and the robot are guiding me to be perfectly in the right spot. So as a surgeon, I do all the surgery, I do all the dissection, we get ready to do the operation, but the machine helps us be exactly to the millimeter, exactly where we want to be. No more guesswork. And even though I've done thousands of shoulder replacements, it's this level of precision that's frankly glorious. So it's this Rosa robot that is simultaneously accurate, efficient, surgeon-centered, and data-driven. Rosa, by the way, stands for robotic stereotactic assistance. That's why it's called the Rosa robot. Coming down the pike, of course, will be the ability to use this type of virtual reality, so-called mixed reality, where I can still see and operate, but have all of this imaging in front of my face. And this is also going to be an incredible way to do a total shoulder. Now, part of the reason I'm excited about all this technology is I've studied technology. I've studied scientific revolutions. In fact, I wrote a book about it that came out a few years ago called The Invention of Surgery. And exceeding my wildest dreams, my book ended up being in the Wall Street Journal and the New York Times and the New Yorker. I ended up being on NPR. And I've thought a lot about what it is about what makes technological revolutions possible. Amazingly, a documentary was then made based on my book, and I love the ending of it. And I'll play it for you.
Future is wide open surgery.
It has been a long road from the bloody beginnings to the high-tech surgery of today. And the journey is not over. Modern surgery is constantly changing. Then and now, it is a story of invention.
So it is an amazing time to be a surgeon. And I'm so proud to be partnered with Zimmer Biomet for their ZB Edge technology, where it's this incredible combination of robotics and intelligence, artificial intelligence, tracking. There's no company in the world that's as advanced as Zimmer Biomet is. And again, there I'm standing with the Rosa robot. It's an incredible time to be a shoulder surgeon, and I couldn't be more thrilled on how much better orthopedic surgery has become because of technology. And of course, it's all about outcomes we care about. It's the ability for patients to do better and faster with less invasiveness. And that's really what robotic applications are. The ability to be more precise in getting patients healing better and faster. Thanks.